Can you hear me? Yes.
Okay. Finally, we are back to the session after due to the network issue. I'm feeling very sorry. I'm for students in this hectic time. Okay. Now we will continue with the session without wasting any time. Okay. We will start with the first question now. So, what is the time taken? I will just draw here. You can see that.
Your
Your
voice is
voice is
clear?
clear.
Now
Now
can you
can you
hear my
hear my
voice?
voice?
Can you hear my voice? Yes. So what is the time taken for the complete regeneration of the placental site? Yes. So you all know the answers. I am seeing in the chat box that everybody is just commenting, sir. Now voice is clear, I guess. Now my voice is clear. Yes. Fine. So sorry for the delay. Now we will see the answers. So you all know that it is based on the OBG questions that the 6 weeks, the standard accepted duration that the placental site healing. We are talking about the puparium part. So the 6 weeks, that is 42 days that we can see. So what exactly happening? What is the placental site with decidua basalis? Okay, which undergoes regeneration after the delivery through endometrial repair and re-epithelialization. So what is this process? Gradual, and it involves, first there will be sludging of necrotic tissue. What there will be? Sludging of necrotic tissue. Then the regeneration of the basal epithelium of the endometrium will occur. Then restoration of the uterine lining will take place. That we will name it as uterine involution. The complete regeneration takes approximately 6 weeks. So that is the answer. Okay. Now the voice is clear. I think there is network issue from your side. I am hearing. So my voice is clear. Okay. Coming on to the distractors part, here it is 2 weeks, not it is not a 2 weeks, and the transition Okay, if we talk about first 2 weeks, there will be lochia will be present, right? So initial healing part will be taking place. If they ask about initial healing, if they talk about initial healing, then it is 2 weeks. So and where lochia rubra phase is there, lochia rubra is there. Then the placental style, the site is still undergoing necrosis and sludging. It is not a complete healing part in 2 weeks. Is it clear? Then we talk about 4 weeks. Endometrial restoration is incomplete. Partial regeneration has happened. So what is the question they have asked? Complete regeneration of the placental site. So it is always 6 weeks. The another one MCQ part is initial healing, where the lochia rubra is present. Okay. So coming on to the 8 weeks. If they talk about the 8 weeks, it is overestimation then. Okay. Already we have told that it is 6 weeks. So the distractors part, the important point is 2 weeks, that it is initial healing phase take place. Complete healing takes place in 6 weeks. Initial healings is 2 weeks. Okay. Voice is clear, I guess. Can you check once more? Let me check. Now it is clear. Is my voice is audible? Kindly confirm, my dear children, so that we can proceed for the next question. Already we are late. Okay. Without wasting any time, we can do. Yeah, it's clear. Thank you. Thank you so much. Okay. Coming on to the next question, very, very important question. Anatomy. If there, yes, it's clear. Fine. So in the pelvic inlet, which is the shortest anterior posterior diameter? So shortest anterior posterior diameter. What is the next question answer? Come on, tell me. So they are talking about in pelvic inlet. So here I will draw the diagram so that it will be easy for you. Okay. Then okay. So consider this as the pubic bone, body of the pubic bone. Okay. Now this will be our true conjugate. This is our true conjugate. What is the centimeter for true conjugate? Come on, tell me what is the centimeter? So this will be the revision classes so that you should give more answers. Okay, you should give the answers. True conjugate is 11 centimeter, right? Yes. So what is the other name for the true conjugate here? Anatomical conjugate. Anatomical conjugate. So coming on to the second point, here we are having obstetrics trick conjugate. Obstetric conjugate. So what will be the third one here? So this is the obstetric conjugate, right? Yes. Obstetric conjugate. Then we will be dealing with the diagonal conjugate. Conjugate. So it is what is the centimeter here is 10 centimeter. Okay. Then diagonal conjugate is 11 centimeter. Now, what is the question in the pelvic inlet? So what is the outlet here? When we talk about this part, okay, from the tip of the coccyx, tip of the coccyx. Yes, am I right? Yes, tip of the coccyx. Here we are naming it as pelvic outlet. Okay, now the diagonal conjugate is 11 centimeter, obstetric conjugate is 10 centimeters. So what is the shortest anterior posterior diameter? So what is the standard if they talk about it is 11 to 12? Okay, when we talk about it is maybe 11 or 12, but the question is about shortest conjugate. Okay, shortest conjugate is obstetric conjugate. So what is the answer here? That is D. Okay, is it clear? So what is the answer? Is D. Is it clear? Yes, yes. So where the fetal head must pass. So that is the obstetric conjugate here. Okay. It extends. Let me write one point. It extends from the sacral promontory to the closest point. Posterior surface of the pubic symphysis. Hence, the fetal head engagement is possible there. So that, okay, yes. So what is the external conjugate? Now tell me. So what is the external conjugate? From where? It is 10 to 11. Here we can say it is 11 to 12. Okay, 11 to 12 centimeter. External conjugate is from tip of S1, that is S1 vertebra, till here we can say, okay, here we can say from the tip till pubic bone. So that we are naming it as external conjugate. Good evening all. Yes, okay, yes. So this is, you will be thinking like a basic question, but it as from, so in prediction series you must understand that the exact question will not come from the question. The concept you should understand. From this there are possible questions according to the upcoming previous NOSET pattern, how they have asked the question, because this type of questions can be asked like maneuvers we have predicted. And after, at the end of the session, I will say some important topics where you should give your focus, so that from OBG, okay, what are the possible questions from the high yield topics, what you can get through. Okay, the external conjugate is from the tip of S1 vertebra till the pubic bone. So that is also an important point that you should understand. Okay, yes. So coming on to the bispannus diameter. So what is the other name? We can name it as mid pelvis. It is not the AP diameter. It is also narrowest transverse diameter. It is the narrowest transverse diameter. Okay, yes. Is it clear? Okay. Shall we move on to the next question? Okay. On the day 5 after fertilization, a developing blastocyst enlarges within the zona pellucida. Which of the following event must occur next to allow the implantation into the endometrium? So you all know, after when the ovulation occurs, when the fusion of the eggs and the sperm is going to happen, the zygote formation is going to happen, the fertilization is going to take place, right? So what is exactly is going to happen? Yes, either there is a differentiation of the inner cell mass into hypoblast and epiblast, or disintegration of the zona pellucida allowing trophoblast connect, that is contact with endometrium, or formation of primary villi from proliferating cytotrophoblast, or conversion of trophoblast into syntrophoblast as it invades the stroma. So exactly trophoblast to into syntrophoblast is not going to happen as a developing blastocyst. Okay, yes. Please zoom. Yes, I will zoom in. Now it is visible. Yes. So the blastocyst must undergo one component, that is, we can name it as hatching. That is disintegration of zona pellucida. Okay, this exposes the trophoblast. This exposes the trophoblast, where it enables direct interaction with the endometrial epithelium. Direct interaction is going to happen with the endometrial epithelium. First, you can just listen, then I will summarize. I will summarize. So, why this step is very important in the sense the attachment and subsequent invasion cannot occur. So, this zona pellucida breakdown is immediate for implantation. Okay, zona pellucida is a responsible person. Okay, where the invasion is going to happen. So the disintegration of the zona pellucida allowing the trophoblast contact with the endometrium. So if it is not going to happen, then the endometrium shuts. Okay, yes. So coming on to the distractus part. So why not A? Anybody can say the answer? B is the answer, right? We are talking about the distractus now. The differentiation of the inner cell mass into the hypoblast and epiblast. Can anyone say this? You can just comment. You can not to type all the concepts, you can just type the keywords. So after occurrence of the implantation, so once the implantation begins, right, on the day of 7 to 8, where there will be the formation of the bilamina cells. So it is not required for the initial, they are talking about the initial attachment. Day 5 after fertilization, developing the blastocyst enlarges within the zona pellucida. It is going to enlarge there. Okay, already everything is happened. Which of the following events must occur? They are asking. Allow implantation into the endometrium. Because once this allowing attachment towards the endometrium, then the proceeding of the next stage is going to happen, right? The implantation, after that it is go day 7 to 8, then the bilamina germ cells is going to happen there. So this is not the answer. Inner cell mass into the hypoblast and epiblast will not take place. First they have to go inside and the implantation is going to happen. Okay, why not C? Occur in the second week. Primary formation of the primary villi from proliferating cytotrophoblast. In the second week of day 11 and 13, it is going to happen. Day 11 and 13. The epiblast, hypoblast and epiblast is going to happen after implantation 7 to 8 days, not in the 5th day. Okay, coming on to the D option. Why not D? This occurs after attachment initially. Okay, when the invasion into the endometrium begins, it is going to happen. When the invasion into the endometrium, where it is immediate after the attachment. Okay, after the attachment, it is going to happen. So that the important point is disintegration is very important. And why not about the zona pellucida region? Come on, tell me what happens in day 5, what happens in day 5 and 6, what happens in day 6 and 7. From day 7 onwards, what is going to happen? So we are talking about sequence of early implantation. Sequence of early implantation. Don't confuse here. So day 5, blastocyst formation. Okay, inside the zona pellucida. Blastocyst formation. So day 5 to 6, what is going to happen? Hatching. Zona pellucida disintegration. Attachment towards the endometrium. Okay, yes, hatching. I told you the keyword. Hatching happens in 5 to 6 days. 6 to 7, what is going to happen? Attachment towards the endometrium. What happens day 7? Trophoblast, differentiation and inversion. Just take the notes. Okay. Very simple question, but you may confuse in your exam. Okay. Yes. Can anyone say what is the layer of zona pellucida? Zona pellucida zona pellucida. What is the layer? It is having glycoprotein layer, which is surrounding the oocyte and early embryo. So that it is very important. Zona pellucida region. Okay, where it allows the sperm entry, everything is going to be taken by this zona pellucida. Okay, yes. Embryoblast, you all know, inner cell mass, the word comes inner cell mass, which give rise to the embryo. Okay, yes. So what will be the nursing part here? If zona hatching, why the hatching is very important? Yes, glycoprotein layer. Why zona hatching is very important? If the zona hatching, the hatching is not taken place, okay, the implantation fails. If hatching is not taking place, if the zona hatching, failure of zona hatching will lead to implantation failure as well as can lead to infertility also. Okay, yes. So that it is very important part. Zona hatching is very important. One of the important point in MCQ. If they talk about infertility, if they want some basic question from anatomy, infertility anatomy, then they can focus on this. Okay, yes. This hatching improves implantation rates. Okay, why we are understanding this implantation timing? Because when we are, so that we are having in the day 5 to 7, right, 5 to 6, so that the contraception measures, emergency contraceptive pill like levonorgestrel if we are going to administer, or oral contraceptive pills we are going to administer, or combined oral contraceptive pills we are going to administer, then This hatching is very important. The days are very important, so that I am keeping stress on this point, hatching. Okay, yes, for implantation, yes, right. Shall we move on to the next question here? By when the fetal kidney start producing urine? So everything you know, right? It is a very basic question. When cardiac activity is going to start? So now tell me, what is the answer? Yes, tell me. See, yes, see. So before that, we are going to see a concept. Okay, fetal kidneys. What's the other name? What is the other name for fetal kidneys? So we can name it as mature kidney or immature kidney or developing kidney. Fetal kidneys, other name. One of the important point MCQs. Fetal kidneys, other names is metanephrons. Metanephrons, which began to function and produce the urine approximately by 12 weeks of gestation. So this nephrogenesis, okay, nephrogenesis starts by starts earlier, fifth week. Here, nephrogenesis starts earlier if they ask about, then it is nearly about fifth week. But functional maturation, if they ask about a word, functional maturation, or start producing urine, then it is around 10 to 12 weeks. So you can choose the maximum, that is 12 weeks. So when the fetal part is going to contribute amniotic fluid to the um, amniotic sac, then by 12 weeks the fetus contributes to amniotic fluid volume through urine production. Okay, this is the important point. Fetal urine becomes the major component in second trimester, that you all know. Major component, the volume that you all know, that is 1000 ml or 2000 ml. So maximum volume of amniotic fluid, which is the maximum time? Can anyone say which will be the maximum time of amniotic fluid? Yes, tell me. It is 12, 1 liter or 2 liters? It is 1 liter or 2 liters? Come on, tell me. Okay, that is the point. 1 liter or 2 liter, it is around 800 ml to 1 liter, that is 1000 ml. So that is one point. So what is a new thing you're going to learn today is stages of renal development in fetus. They can ask questions. Okay, we are having here metanephrons is functional, not functional. Maturation will not happen, but we are having stages. Here functional, non-functional, temporary functionals are there. Okay, we are having pronephrons, that is non-functional, that is early embryonic stage. First point. What is the second point? Mesonephrons, where temporary functions, okay, temporary function is going to take place. Coming on to the metanephrons, where the functional maturation is going to happen. Okay, here what is the kidney, fetal kidney maturation we are talking about? That is metanephron, where functional maturation happens when the kidneys are start going to start produce urine. that is about 12 weeks. Okay. So what is the contribution for amniotic fluid in the first trimester? Can anyone say? You people are not answering. Please, it is nearby exams. We are having some not less than 10 days. Right? 11th is your exam next week. Come on, first trimester. Okay. Without wasting time. In first trimester, it is mainly maternal plasma. From second trimester, fetal urine is the major factor, dominant factor for amniotic fluid. Okay, is it clear? Okay. Here the points which is very important, that is stages of renal development, especially in fetal kidneys. We are having three stages, that is pronephrons, mesonephrons, and metanephrons. In pronephrons, we are having non-functional kidneys, where we are naming it as early embryonic stage. Coming on to the second point, that is mesonephrons, where the temporary function, where it is also immature, okay, temporary function is going to take place. Here we are having the third stage, that is metanephrons, where functional maturation exactly 10 to 12 weeks, where the fetal kidneys start producing urine. So what is the other name for fetal kidneys? That is metanephrons. Here we are having the third stage, that is matured fetal kidneys. We can say matured fetal kidneys. Okay, here nephrogenesis start earlier. When they talk about nephrogenesis, earlier stage, that is fifth week, not eighth week. Very important point. Functional maturation, if the word come, that is around 10 to 12 weeks. Maximum point you should take 12. That is, if they ask about interval point, then you can say 10 to 12 weeks. Okay, is it clear? Okay. Shall we move on to the next question? Yes. Here, the next question is, a patient in the labor room is being evaluated with cardiac topography. Uterine contractions are estimated 7 contractions per 10 minutes. She is receiving IV Pitocin. Which of the following intervention should done next? Come on, I will give you some 10 seconds. You can answer. Yes. Can anyone say why we should put option B, and you can put some rationals. You can take time, you can type. Okay, we are having some good audience, so that you can type why it is. Why we have to stop IV Pitocin. Just a simple word. When we are talking about this topography, here we have to see the component, that is frequency of uterine contractions first, then the duration of the contraction, how many seconds, then the intensity, frequency, duration, and intensity of contractions you should check. Especially when we are administering the drug Pitocin, which group of drug it is? An uterotonic agent, right? It is an uterotonic agent. So that, yes, hyperuterine contractions, yes, right. Ishi Kamalik, yes, you're right, you're right, yes. So here we are having 7 contractions per 10 minutes. Usually, if it is more than 5 contractions in 10 minutes, we are naming it as uterine tachysystole. Okay, tachysystole. So, average over 30 minutes. So, we should stop, because when there is excessive uterine contractions, what is going to happen? If the contractions are high, what is going to happen? Reduced uteroplacental blood flow is going to happen. Reduced which leads to fetal hypoxia and distress as well. Okay, first initial management, immediate management. Once she is giving IV pentosine, which of the following intervention should be done next? Already the contraction is high. So further, we should not proceed the complication. We should stop the complication. So that first we have to stop the IV pentosine. So the option is B. Option is B. Maternal repositioning, yes, we can do, but first we have to stop the IV pentosine. Then, if the mother is having any distress, okay, then we can proceed. Okay. What is the primary thing that you should know when the amnio infusion is going to happen? Here, from this question, from this concept, one question is going to come. You all know about wheel chop. Variable deceleration will be there. Variable deceleration, cord compression. Early deceleration, head compression. Acceleration, it is okay. What is C then? Sorry. Late deceleration, placental insufficiency. When we are going to give this amino infusion, when the variable deceleration is going to happen, okay, that time due to cord compression, we can use this amino infusion to protect the fetus. Okay, yes. Pitocin is a uterotonic agent. Where is pitocin written? Yes. Pitocin, it is an oxytocin analog. Okay, synthetic analog. Synthetic if you are giving overdose of pitocin, what is going to happen? Hyperstimulation is going to happen. Okay. Now we are going to see the stepwise management. So already I told the management, but first two steps we have discussed. First we have to stop the pitocin, then we have to do the maternal repositioning. What is the preferred position? Anyone can say? Steps of management, tachysystole. Yes. First step, what we have told, stop IV pitocin. Second step, maternal repositioning. What is the position? Preferred position, very important point. Very important point. What is the step? Yes, left lateral. Correct. Ashu Devi, you are correct. Left lateral. Coming on to the third point, oxygen administration. Because there is, here we'll be having confusion whether we have to give oxygen first or positioning first. Here, IV pitocin is there. First positioning left lateral, then give administration of oxygen, then proceed with IV fluids if anything given by the doctor. Then we can go with toco like this. Especially nowadays, terbutaline is considered. is considered. Okay. Yes. But as a nurse, you should be conscious about the frequency, the duration, and the intensity of the contractions that you should know, and you could recognize this earlier so that you can prevent the complication. This is probably the nurse's duty, okay, to prevent fetal distress, acidosis, and any adverse outcomes. Okay, yes. Here, the patient will be in distress. There will be hypoventilation. So the pH drops. Okay, there will be respiratory acidosis, most probably. Okay, yes. Yes, correct. Sunny Meena, you are correct. Pitocin causes water intoxication during pitocin administration. Monitor intake output dose also. Yes. So the most probably the major component is first you have to assess the contraction. If the patient is in CTG, okay, if the patient is in topography monitoring, first we are having the baseline there. First we have to assess the contraction, then any physical symptoms is present or not, then we can proceed the management here. So it is a nurse's duty. We cannot ask the time. The patient is already in vulnerable situation and already life threatening situation. First we have to stop the pitocin, then positioning, then we can give oxygen administration, then we can inform the physician there. Then probably IV fluids is not indicated. We cannot give as much directed, but we can inform after that if the scenario is like that. Okay. Yes. Shall we move on to the next question? Yes. Sixth question. See, arrange the following steps of IUCD insertion in the correct sequence. Now you are going to answer. So what? How IUCD is working here? Principle of action of IUCD. You all know copper T380A, 10 years, and now we are having levonorgestrel releasing hormonal IUCD. Hormonal IUCD. IUCD is also there. That is levonorgestrel. Sorry, you can arrange the sequence. Okay. Yes. So what is the principle of action here? I will write here. Now you are going to answer. Okay. Okay. Somebody is answering. You are right. Parchi Verma, why C you are given? Okay. Let me discuss the principle. Then we will be discussing the steps. Copper IUCD here, which causes spermicidal inflammatory reaction. Where the hormonal IUCD. This is hormonal. Okay. Hormonal. Hormonal IUCD, how it is going to work? Thickens the cervical mucus and suppress the endometrium. Suppress the endometrium. If endometrium shuts, suppressing the endometrium, then how the fertilization is going to take place? Okay, if spermicidal reaction is going to happen, how sperms are going to penetrate there? Okay, inflammatory reaction is there. Okay, it is not possible to penetrate. So that IUCD works on that principle. So coming on to the points, first we have to perform pelvic examination. Okay, which assess the uterine size, position, and rule out the contraindication whether we can proceed the next sequence or not. Then do grab cervix with for instrument, that is balsam forceps or Ellis forceps. Okay, valsalbum. Valsalum or Ellis forceps, which stabilizes the cervix and aligns the uterine axis. Okay, yes. Coming on to the third step, mount IUCD into the introducer. That is, prepare device for insertion first, then prepare the device. What is the fourth step here? IUCD insertion, that is push in we have to do. That we are naming it as withdrawal technique. Correct placement we have to do. That is the fourth step. Withdrawal technique, correct placement. Then fifth step, cut thread into two required length. Avoids discomfort, that we have to do. Then we have to knee. Now we are going to do order the sequence. First is this point. Perform pelvic examination. What is the next point here? Next point is grasp the cervix with valsalbum or Ellis forceps. Coming on to the third point. So what is the third point here? Cut the thread or mount the device into the introducer. Yes. It is insertion is going to take place. Then withdrawal technique. Okay. That is the third point. That is the fourth point. What is the fifth? Cut the thread according to the required length. Why in the sense? Which ensures the future visibility. Okay. Which avoids discomfort too. So the answer is B. Okay. Is it clear? Okay. Then post insertion. What the nurse do? Post insertion. Nursing action is educate the patient to check the IUCD thread. Very, very, very important point. Educate the patient to check the IUCD thread and also educate. Then what about the complications? Like if there is any pain, bleeding, or any expulsion is going to happen, then we have to check that also. We have to educate the woman who is undergoing this IUCD. Okay, yes. Yes, thank you. Sunny Mina, you're right. Yes, prevent fertilization. Thank you so much. Please be interactive because you should brainstorm yourself. Lot of concepts are there. It is very difficult to understand and you have to regain lot of concepts. Okay, in your exam, you'll be very panic or don't be panic, be relaxed. We are having good amount of 18 to 20 minutes there. Okay, 20 minutes are there, 18 minutes are there. You have to attend some 20 questions. It is not, it is difficult, I know, but first two sections. Okay, let me spare some good time there. Okay, A, B, C, D, E. So these are the section 1, 2, 3, 4, and 5. I am talking about NOS set. NOS set. In first section, you are going to attend 20 questions, 20 questions, 20, 20, and 20. So this fifth section is non-nursing part. I am not talking about that. Anyway, 10 questions will be easy. If you study or not going to study this, 10 questions is very easy questions only you are going to attempt. So what about the nursing part? When we divide this 40-40, the first two sections, either A section or B section will be very tough. Very tough. It will be confusing questions or anything. These two sections will be very easy as per the prediction. So your prelims paper will be average to easy. Easy to average we can say. Medium difficulty or I am just telling. Okay. The same pattern which followed in previous sets is going to be the same. Okay. Either it will be like easy to moderate or it is a moderate question paper. The first two sections you should be very cautious in choosing the questions. First 1 or 2 minutes or any one you can spend the time. Just analyze the question paper. For you just click, go to the first question till the 20th question. You can see the questions, how the questions are. If it is more scenario based, if they were asked, then it is a very difficult section. Then you should be focused. Okay, this paper is going to be very tough. Don't think like that. You should analyze the section wise. Oh, okay, this section is difficult for me. Then you should control your negative markings there. You can take risk on C and D, that is third and fourth section, not in the first two sections. Not in the first two section. Okay, you can attend some good number of questions. You can attend some 80 plus questions. That is not a matter here, but section wise, analyze and answer. Okay, yes. So coming on to the next question, shall we proceed? Yes. A 29-year-old woman with 10 weeks of amenorrhea present with painless vaginal bleeding. Okay, amenorrhea they are telling. Okay, her urine pregnancy test is positive, but her ultrasound shows empty uterus. No gestational sac was found in the adnexa. An ectopic pregnancy is suspected. All of the following features are favor clinical diagnosis of cervical pregnancy except. Is come on, enlarged cervix equal to or larger than the fundus, or a fully opened internal cervix, os, or products of concepts attached within the endo cervix, or partially opened external os is there. Yes, come on. Yes, it is cervical pregnancy. So it is a rare condition, which is a rare type of ectopic pregnancy occurs within the endocervical canal. So what may be the clinical features here? Painless vaginal bleeding. Then there will be enlarged cervix. Enlarged cervix will be there. That we are naming it as hourglass uterus. That is appearance. Enlarged cervix. Hourglass uterus. So there will be products of conception located within the endocervix. External os must be open, but internal os remains closed. Okay. Yes. Except they are asking. The question is except. Enlarged cervical equals larger sphincter will be there. Products of concepts attached with the endos within the endocervix will be there. Partially opened external os. Yes, there will be possible of external os is open, but internal os is closed. But the answer they are asked about except. So the answer is B. Okay, is it clear? Okay. So next question we are proceeding. So the traditional question comes RH components. Yes, RH negative primigravida as second trimester abortion and indirect womb test done on the maternal serum is positive. According to the ACOG guidelines, American standards, which of the following is to be done to prevent RH isoimmunization? So first, we have to know the dosage first. So what is the dosage here? So if it is in first trimester, okay, anti-D if you are going to give, the abortion is there less than 12 weeks, then it is 50 mcg. If it is more than 12 weeks, this is always a confusing question, but this is an updated one. 300 mcg or 1500 IU. Okay, yes. So now what is the answer? So indirect womb test which detects the circulating antibodies, yes, in the maternal serum, which is going to detect circulating antigens, anti-D antibodies in the maternal serum. If the negative ICD patient is unsensitized, okay, yes, the component that is administer 300 mcg of anti-RH antibody within 72 hours. Okay, yes. Any doubts? If it is less than, that is in 12 weeks, then it is 50 mg. This is for abortion. And it we have to give. If it is in first trimester. Okay. Yes. Yes. Answer is C. Shall we move on to the next question? Yes. So what is the dosage of levonorgestrel? Mala D. Mala N, Mala D. Yes, come on, tell me. So first of all, what is Mala D? COC. Combined oral contraceptive pill, which is used in national family planning programs. Okay. What is the composition here? Ethylene, ethylene estradiol, where the estrogen component. And levonorgestrel. So now tell me what is the dosage. So what is the dosage of antra? Antra. Not kantara, antra. Good evening. Yes, 150 every 3 months. 3 months. That is antra. So here, same thing, but MCG. Just I am giving you the clarity. Don't confuse. Okay. Levonorgestrel, that is Mala D. The composition is ethylene estradiol and levonorgestrel. Here we are going to give 150 mcg. Okay, mcg. So this dose provides what? Ovulation suppression, thickening of cervical mucus, endometrial changes will be preventing for implantation. Okay, this is the very important point. Okay, suppressing ovulation and thickening of the cervical mucus. Okay, that is the important function that you should know. Okay, yes. It alters the endometrium. Actually, what it is going to do, it alters the endometrium. If endometrial layer is altered, then how the ovulation is, then how the fertilization is going to take place. Okay, when how the implantation is going to occur. Okay, that is the important point. So next question, a vaginal delivery is complicated and the maneuver shown in the image is performed. So despite correct technique, the fetal shoulder remains impact. What is the next step of management? Now tell me, so what is the technique they have used? Yes, correct. Sunny Minya, you are correct. See, in prelims, your questions will be simple. Okay, it will be simple. I am telling you 60 to 70% you can attempt. Okay, yes. It is, what is the technique they have used? No, we should. So they are told about fetal shoulder remains impacted. What is the next recommended step they are asking? For shoulder dystocia, what is the manual we'll be using? Now tell me, for shoulder dystocia. Yes, for shoulder dystocia, which manual we are going to use? Yes, that is Meg Roberts manual. What they have asked, despite correct technique, the shoulder remains impact. So first point, what is the standard management? First, we have to give McRoberts manual what they are doing, suprapubic pressure, first line they have given. So if it's unsuccessful, what is the next step? Internal maneuvers will be doing. That is wood screw or Rubens manual. Further, we will be doing the internal rotation. Okay. First, rotate fetal shoulders into the oblique diameter, then we have to do that. So what is the answer is, we have to perform internal rotation of the maneuver. Okay, internal rotation maneuver, that is Rubens maneuver we should perform, because the fetal shoulders are impacted there. Okay, then what we have to do? We have to perform internal rotation of the maneuver. So why not a, if we are positioning the mother on the hands, then it is Gaskin maneuver. GASKIN. Okay, it is not the immediate step there. When there is suprapubic pressure is given, then it, if it's unsuccessful, again the shoulder is being impacted there, then we have to do internal rotation, which facilitates the delivery. Okay, the major component is it reduces the bi bisacromal diameter, reduces the bisacromal diameter, so that we are doing this internal rotation maneuvers. Internal rotation maneuvers are what? Rubens maneuver. Rubens maneuver. So what are the key integrated concept here? Shoulder dystocia is a very important condition, failure of shoulders to deliver after the head. So if it is an risk there, then what is going to happen? It is an obstetric emergency where there will be fetal hypoxia as well as brachial plexus injury. Okay, is it clear? Okay. What will be the next question? Shall we move to the next question? Okay, already we are late. Now I'm going to be little fast. Please be on time and be follow me. Okay, yes. Normal uterus and vagina with streak gonads, where we'll be having 46XY karyotype is seen in. Okay, yes, come on, tell me what is the answer. Here they have given steak ovaries. Now we are going to learn about the gonad, that is where the steak ovary is going to happen. Here I'm going to write Sayre syndrome, Turner syndrome, then what is the other syndrome there? Androgen insensitivity syndrome, right? androgen insensitivity syndrome. Then the last option is Mayer-Rokitansky-Kreuzer-Hauser syndrome, MRKH. Okay, we'll write like this. So now, what is the karyotype is 46XY. For Turner, it is easy, 45XO. And androgen insensitivity syndrome, okay, insensitivity syndrome, sorry, that is also 46XY. And MRKH also 46XX. Now, what about the uterus and gonads? If it is uterus is present, okay, Turner syndrome, uterus is present. What about androgen insufficiency, insensitivity? Here, uterus is absent. And MRKH here, 46XX, uterus is absent. Coming on to the gonad part, here for Sway syndrome, streak ovaries. Streak will be there. Streak uterus will be there. Sorry, streak uterus. Turner syndrome, streak ovaries will be there. Coming on to the androgen insensitivity syndrome, that is, testis will be present, but uterus is absent. Okay, yes. MRKH, that they resembles with male characteristics. Here, Sway syndrome has the component of male, but insensitivity will be there. Okay, sex determining gene will be not will be there. Okay, yes. Here, what is the question? Here, streak gonads will be there. Sway syndrome, streak gonads will be there, where non-functional gonads. Okay, gonads, normal uterus and vagina for female if it is there. Okay, that is we are naming it as gonadal A dysgenesis, non-functional, abnormality. Okay, gonadal dysgenesis. Simply, I can say that is failure of testicular development. That is SRY gene dysfunction, sex determining gene. Okay, yes. You all know about the Mullerian structures results. Mullerian structures develops uterus, fallopian tube, and vagina. Okay, no male differentiation is there. Okay, yes. Shall we move on to the next question? Okay. Yes, absent uterus, you are right. So from this, possibility of MCQs are there. Here I am talking about gonads. In Turner syndrome, streak ovaries will be there. Okay. What about MRCH, MRKH, normal ovaries will be there. I think no need to explain about X and Y. X is female characteristics and Y is male characteristics. If Y is there, male components will be there. But if it is an chromosomal defect, then there will be abnormality in sex determining hormones will be down there, and there will be underdeveloped functional underdeveloped testes will be there. Okay, yes, due to the impact of testosterone hormone. Okay, now shall we move on to the next question? So what is the answer? That is Say syndrome, because normal uterus and vagina will be there, but streak gonads. Normal uterus and vagina will be there, but streak gonads is the component, so it is Say syndrome. In Turner syndrome, there will be streak ovaries, 45X0. Okay, here both male and female characteristics are there, but underdeveloped male characteristics. But normal uterus and vagina will be there. Okay, resemblance with male characteristics. Is it clear? Okay. So coming on to the next question, a primigravida is active labor present with diamond-shaped fontanelle that is distinctly felt and lies lower than the triangular-shaped fontanelle. And the examiner can palpate the root of the nose, but is unable to reach the chin. Which fetal head diameter is most likely engaging? Yes, Sunny Mina, you're right. For the last question, I have seen the command. Okay, McRoberts, then Rubin, then last is zonal maneuver. So for all the audience, okay, first is McRoberts maneuver. If it is unsuccessful, then we have to do the internal maneuvers. That is what? That is Rubin maneuver, and then we can proceed with wood screw maneuver. Okay, wood maneuver we can see. So what is the answer for this question? 12th question. Yes, come on. Yes. So diamond shaped frontal is anterior frontal or posterior frontal. Diamond shaped, if they for the diamond shaped, okay, diamond shaped frontal. Diamond shaped, if they ask about, it is anterior frontal. Okay, yes. Now we are going to discuss about attitude, what is the presentation, what is the diameter, and what is the size. Okay, yes. So now tell me if the attitude it is vertex. What is the diameter? Suboccipito-bregmatic. If it is 9 point. Whenever the word comes bregmatic, it is 9.5 centimeter. When it is a neutral, when the attitude is neutral, then it is presentation is military suboccipito frontal. Frontal, it is bregmatic. Okay, then what is the size? It is 10 to 10.5 centimeter. Okay, then what about partial extension attitude and full extension? Partial extension, that is with bro. Presentation is bro and it is mento vertical. When there is a full extension, then it is the presentation is face. It is mento bregmatic. Whenever the word comes bregmatic, it is 9.5 centimeter. Partial extension, bro presentation, mento vertical, it is the largest, that is 13.5 centimeter. You all know diamond shaped is anterior frontal, posterior is triangular shape. Okay. Then what is the answer here? Which fetal head diameter is most likely engaging? Here they have given the keyword. Okay, like lower than triangular shaped frontal, diamond shaped frontal. Then palpate the root of the nose. They can palpate the root of the nose palpable, but chin is not palpable, right? Chin it is not reachable, so it indicates incomplete extension. Incomplete extension is bro. Partial extension. Incomplete extension is, what is the keyword here? Where is incomplete? We have read the incomplete, right? The examiner can palpate the roof of the nose but unable to reach the chin. So partial extension. Indirectly they are telling it is partial extension. So then the answer is mento-vertical. This how you should analyze the question. So when we talk about the other components, when the word comes, can able to reach the nose and there is they can able to reach the chin, then it is full extension. The presentation is face, then it is submentobrygmatic, then it is 9.5 centimeter. So this how you should analyze the question. Then they put a word about flexion. Then if it is a vertex presentation, then it is occipitobrygmatic, it is 9.5 centimeter. Okay, this how you think it is an easy question, but when they put in the scenario, so what you will do? Okay, flexion, vertex, suboccipital pragmatic 9.5. Oh, okay. 9.5 pragmatic is 9.5 centimeter. We know. Okay. We'll read. We will read like this. But in question paper, it will be like scenario. Once again, I will put a stress. A primigravida is active labor present in diamond shaped fontanelle. So one thing is confirmed, that is anterior fontanelle. Okay. Which will be front prominently lower, that suggests extension. Okay. Yes. Then if it is posterior frontal, so what it will be? Anyone? Okay. Now that is distinctly felt and lies lower than the triangular shaped fontanelle, and the examiner can palpate the root of the nose but unable to reach the chin. Okay. They if the word comes, they can reach the chin, then it is fully extended. Then it is submentobrygmatic. It is a face presentation. Okay. Yes. So the keyword is very important there. Okay, coming on to the denominator. Coming on to the denominator part, if it is an vertex, occipit. If it is face, then it is mentum. When it is brow, it is frontum. Okay, yes. So coming on to the nursing relevance, if it is a brow presentation, it is obstructed labor. Most probably there will be obstructed labor. That you should know. Obstructed labor will be there. Okay, increased risk of cesarean delivery is also possible. Okay, yes. So coming on to the next question. A 13-year-old lady came to your OPD with complaints of non-foul smelling, curdy white vaginal discharge with itching and burning. On examination, the vaginal pH is found to be 4.5 less than. Okay. When the causative organism is incubated in human serum at 37°, the germ tubes are formed. How would you treat a partner with this condition? So first analyze what is the condition. First analyze what is the condition. Ideal question. Okay, last time they have asked about septic, that is about labor, sepsis. Okay, abortion, missed abortion, I think, or septic abortion. They have asked about septic abortion question in prelims. They've asked about the further management. Whether you will start the IV fluids first, or you will start with antibiotics, or the patient is having already sepsis. First, we have to analyze the fever, or what is the scenario. Like that, we have asked about one abortion question with anti-D. Last time anti-D question was not asked. This time it is predictable. Okay, yes. Now tell me. Candida albicans, yes. It is vulvovaginal candidiasis. First of all, it is vulvovaginal candidiasis. Now tell me, what is the treatment required? This Candida albicans, you are right. Anushka Kandu, Stiram, Stipar, na. Matei. Yes, correct. Sorry for the pronunciation. Krunal Sharma. You're all correct. It is candidiasis. So Candida albicans. But germ tube formation is formed. It is fine. But non-foul smelling curdy white vaginal discharge with itching and burning is only there. Okay. This vulvovaginal candidiasis, VVC, vulvovaginal candidiasis, primarily not transmitted sexually. Okay, primarily the treat so that there is no treatment required. Okay, no treatment required for this treatment for this condition, especially vulvovaginal candidiasis alone. Okay, yes. So, what will be the predisposing factors for vulvovaginal candidiasis? That is diabetes, pregnancy, and antibiotic use and immunosuppression. What is the diagnostic feature if they ask? Thick, curdy, white vaginal discharge. That is the germ tube positive will be there, and pH is acidic maintain 4.5 less than 4.5. Okay, what is this germ tube test? Important MCQ point. Formation of filamentous outgrowths from yeast cells, which identifies the Candida albicans. Which identifies the Candida albicans. What is the term for named balantitis? Balanitis. Sorry, balanitis. 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 Blantis is the inflammation. Gland pains. Then the treatment is required. If the partner, if they put the word partner is having symptoms, partner is having gland penis inflammation, then we can proceed with the treatment. Okay, yes. Now I will explain. Here they are not talking about the candidiasis alone. Here the condition what they are given, non-foul smelling, curdy, thick vaginal discharge, white color they have given, along with itching and burning sensation. And the pH is also maintained. If it is a candidiasis which is not in the vulvovaginal, it is in the vaginal region, then there will be thick vaginal discharge, foul smelling, whitey patches also will be there, and discharge is also there. Then we can proceed with the treatment. But their condition specifically here it is vulvovaginal candidiasis. If the word comes vulvovaginal candidiasis, then there is no treatment for the partner unless the partner is having treatment. No prevention of care because it is not going to be transmitted sexually. Then why we have to treat? That is the point here. Okay, yes. They're talking about treatment for the partner. Can you tell me in English? Because I'm not that much good in Hindi. Okay. So next question. A 30-year-old lady presented with 5 weeks of amenorrhea and positive pregnancy test. She is known case of anti-phospholipid antibody syndrome, and her previous medical report shows that she has cortical vein thrombosis during her last pregnancy. Okay, which of the following prophylactic measures should be undertaken to prevent reoccurrence of such thrombolytic events? So now tell me what is the answer. Close monitoring during antepartum period with postpartum heparin, heparin throughout the pregnancy and 6 weeks postpartum, postpartum heparin 4 to 6 weeks, antepartum heparin during third trimester with postpartum monitoring. Yes, what is the answer for the 14th question? Yes, come on. What is the answer for this question? B. Heparin throughout the pregnancy. So, if the word comes autoimmune disorder characterized by the anti-phospholipid antibodies, then there is hypercoagulable state. We can say that is hypercoagulable state. Hypercoagulable state, that it is risk for reoccurrence of atrial or venous thrombosis. Pregnancy complications can also occur, like abortion, placental insufficiency can also occur. Okay, yes. For that, anticoagulants they have to take heparin throughout the pregnancy and also 6 weeks postpartum. Okay. When does the placental healing time occurs? Come on, tell me what is a week? First question, what we have discussed, that is 6 weeks. Okay, the same thing, 6 weeks, the components, the age, the centimeters, diameters, everything you should remember before the exam. Just have a glance and go. Okay, then what is the next question then? You asked to assist with the tubal sterilization procedure during your residency. The senior resident performs the following type of sterilization procedure. This technique is known as Uchida's procedure, Ivering's procedure, Coran's procedure, Pomeroy's procedure. See students, overall your plan C subscribers, whomever subscribers, you can raise your concerns on the given mail ID. Support system is there. Okay, here the point is prediction series. We are going to discuss the components. Okay, don't disturb the audience. That what my humble request is. We are having support system that everybody can will be supported and your queries will be resolved. Okay, okay. Now tell me what are the procedures here. Uchida's procedure where the injection of saline to separate the tubal layers followed by excision. Here, Pomeries that we are going to uh, tie ligate and we are going to tie in the both the ends, especially in the nearby part of the ambulant isthmus, right? Yes. Here, this is the in the isthmus part. I'm going to tie 2 knots and I'm going to ligate the remaining portion. Okay, this is the permanent sterilization method. Okay, first Uchida's procedure is I'm going to inject the saline to separate the tubal layers. Then what I'm going to do, and I'm going to exit it, that is burying the ends, not fibrinectomy I'm going to do. No fibrinectomy. This is not Uchida's procedure. This is what procedure? Coran's procedure. Coran's procedure. Okay. Crow-Enner's procedure. This is not the technique. Okay. Yes. First, I'm going to discuss Uchida's procedure. So this is the Uchida's procedure. You can see there. First, inflammation. I'm going to inject the saline. What I'm going to do? It is going to inflame. Then I'm going to ligate. Cut and ligate. Tie the knot and I'm going to ligate. Okay, this is the technique. Not fibrinectomy I'm going to do. Okay, yes. So this is the Ivering procedure. This is Pomeroy's procedure. And I'm going to tie the knot and I'm going to cut the tied knot procedure. Okay, portion alone, the stimulus part alone is going to be removed. No fibrinectomy. Part gland, you can see the knot is tied and I'm going to remove the remaining part. Here, Mandlana Here I'm going to tie the knot alone, not I'm going to do any excision. Here, coroner's procedure, fibrinectomy can be performed. Okay, fibrinectomy is not also, it is left alone. Okay, it is fibrinectomy. Coroner's fibrinectomy is also there. Okay, yes. Fibrinectomy is done. Yes. So now tell me whether in the given picture is coroner's procedure or Pomeroy's procedure. Yes, whether it is Pomeroy's procedure or coroner's procedure. It is coroner's procedure. Okay. Yes, it is coroner's procedure only. When the part is ligated, okay, joint and ligated, knot is tied, then the part is removed, then it is what? Pomeroy's procedure. What is the modified Pomeroy's procedure? This is the Pomeroy's procedure. This is coroner's procedure. Okay, this is Mandler procedure, where the cut is not made. When the cut is made, ligated and cut is made, then it is Pomeroy's. Okay, don't confuse. Okay, yes. For me, while remembering this, it feels difficult. Okay, but you should have the clarity. Okay, when the saline is injected, this Uchida's procedure, that is, you all know. Ivoring's procedure, you can see the image. The part is removed and it is attached towards the part. Okay, yes, it is attached, not ligation. Okay, and fibrinectomy is also not done. Modified cut and tie. Yes, you're right. Shall we move on to the next question? Okay. If the division of the inner cell, okay, yes, next question is the division of the inner cell mass takes place within 3 days of fertilization, it results in the formation of monochorionic monoamniotic twins, monochorionic diamniotic twins, dichorionic diamniotic twins, conjoined twins. Yes, tell me. The inner cell mass takes place within 3 days of fertilization, then it is dichorionic diamniotic twins. Okay, independently with its own chorion and amnion. Own chorion and own amnion. Okay, that is the major component. What about the monochorionic and monoamniotic? Late, that is 8 to 13 days it will take. What about monochorionic and diamniotic? It is between 4 to 8 days. What about conjoined twins after 13 days? What about dichorionic diamniotic? It is within first 3 days. Okay, this is the exact thing you should know. So coming on to the next question. A 35-year-old woman, G3P2 at 12 weeks of gestation, present with prenatal visits. A screening test revealed increased beta HCG, decreased pregnancy-associated plasma protein A, and increased knuckle transparency on the ultrasound. Which diagnostic test result should be most appropriate to confirm the diagnosis? Tripolydin amniotic fluid or additional chromosome in placental tissue, decrease estrogen maternal serum, and free fetal DNA in maternal serum. Yes, come on. Increased knuckle transparency is also there. If the patient is in first trimester, if the beta HCG is increased, first beta HCG is increased. Then what about this PAP-A? Pregnancy associated plasma protein is also decreased and knuckle transparency increased. It indicates highly suggestive of which syndrome? Which syndrome? That is trisomy 13 or 18 or 21. Yes. Refer your notes. Trisomy. Yes, it is Down syndrome. Correct. Trisomy 21, Down syndrome. The screening test indicates the risk. It is not the diagnosis. Okay, always remember this. The presence of extra chromosome. Here, the presence of extra chromosome in placental tissue confirm the diagnosis. So, there will be additional chromosome in the placental tissue if it is increased the first trimester. So, chorionic villi sampling. Chorionic villi sampling is about 10 to 13 weeks. Obtains placental chorionic villi tissue. Okay, this is the best diagnosis we can do. Okay, additional chromosome that is with 21, trisomy 21. Okay, yes. What about C and D? What about A? Come on, tell me. See here, additional chromosome in the placental tissue. See, confirms of aneuploidy, but it is not a definitive diagnosis. It is a screening. When we talk about definitive diagnosis, that is CVS. That is done in 10 to 13 weeks. Is it clear? Okay. What about C option? Decreased estriol in maternal serum. It is a part of second trimester. It is part of second trimester and quadruple test. It is not confirmatory, we can say. What about free fetal DNA in maternal serum? It is highly sensitive screening, but it is not confirmatory. Okay, that is also not recommended here. It's clear? Shall we move on to the next question? Here comes the point. What is the correct formula to calculate the total iron dose required in mg for parenteral therapy in a pregnant woman with iron deficiency anemia? Yes, tell me. I will give you the time so that you can answer. So first is total iron dose is equal to, that is in mg. What they have given iron dose that we have to calculate. So what is the formula? 2.4 into body weight. Okay, body weight into open bracket, we have to write the target HB minus actual HB plus 500. So this is the formula, total iron dose. 2.4 into total body weight is 60 kg. And what is the target HB they have given? That is 11. What is the actual HB? 8. Answer. So if we calculate in precisely, they have not asked about the total iron dose. They have given the formula here, 2.4 into 60 11 minus 8 divided by 11, or it is actual. What is the target HP and actual HP plus 500? So now it is B. 2.4 into 60 into 11.11 11 minus 8 plus 500. Okay, is it clear? So this is the formula. 2.4 into body weight, target HB minus actual HB plus 500. Okay, so the answer is this. It's a new learning for you today. Already you have learned standard formula for parental iron requirement. Okay, total iron dose. So if they are talking about parental therapy, if the target HB is less than 7, then we can proceed with parental route. Okay, yes. So what is the next question? Match the following parameters of pregnancy with their typical change. RBC mass, albumin levels, plasma protein concentration, fibrinogen levels, and residual volume of the lungs. Change. RBC. Now tell me, easy question. Blood volume increases or decreases? Yes, tell me, blood volume increases or decreases? So now we are going to do the interaction, right? RBC mass increases due to erythropoietin stimulation. Erythropoietin stimulation. Albumin levels will be decreasing. How? Due to hemodilution. Because albumin maintains the oncotic pressure. Okay, hemodilution take place there. Plasma protein concentration. Plasma protein dilutional effect will be there. Overall protein concentration will be decreasing there. So that plasma protein will be decreasing. What about fibrinogen levels? You all know pregnancy is in hypercoagulable state. So there will be increased fibrinogen will be there. What about residual lung volume? Diaphragmatic elevation will be there by the gravid uterus, so that the residual lung volume decreases. The residual lung volumes decreases. Right? So now what is the option? RBC increases. Okay, all options are there. Albumin level decreases. Only two options are there. Either A or D. Either A or D. So what is the answer? Then plasma protein decreases. Here it is increases, so it is not. So the answer is D. The answer is D. So first you have to analyze. So what happens to the HP? So what happens to the RBC? Albumin will be decreased or not? Plasma, fibrinogen. So they are talking about physiological changes during pregnancy, right? Yes. So next question we are going to discuss, that is the last question. Okay. Which of the following maneuver was carried out during the vaginal delivery? Why this maneuver is carried out? Delivery of the external arms in breech presentation, relieve shoulder dystocia during vaginal delivery, deliver the after coming head in the fetus, delivery of the extended legs in the breech presentation. Yes, come on. Yes, come on. We are having 23 participants. I need answer from you all people. Please answer. It is C or D? Because this is our last question, right? Delivery of the extended arms in the breech presentation, or relieve shoulder dystocia during vaginal delivery, or deliver the after coming head in the fetus. Okay. What is the maneuver there? Yes, come on. Prex maneuver? No, it is not the preg maneuver. Here they're telling about after coming head. Here you can see after the head is came. Okay, so the given maneuver is the fetus is already delivered up to the body. So it is carried on in breech presentation, first of all. So the head is still inside the birth canal. So placing the fingers, the maxilla, not on the throat to maintain the flexion, the body is supported with the forearm. Then gentle downward and upward traction is needed to facilitate the head delivery. So that deliver the after coming head in the fetus. So that is the option. Delivering of the extended legs in the breath presentation. Already it is done. So the body is already removed. Only they are giving the support to the forearm, not on the face, not on the only in the shoulder area. They are going to give the pressure, and they are going to deliver the baby in the downward, gentle downward and upward traction to facilitate the end delivery. So it is not fixed maneuver, it is Merrick Smiley Viet maneuver. What is the other name we can say? So the entire part is delivered. Okay, the breech presentation. Okay, so delivery, the option C is the answer. Okay, no shoulder dystocia, delivery of the extended arms, the breech presentation, because already they have done all the extension. After coming head, they have to do the delivery. Okay, first we have to deliver the fetal head. So that is the next point. Okay, the answer is C. So we are completed our prediction series for OBG questions as per the experts' opinion. We have done this. Okay, what are the maneuvers especially used in breech presentation? That is pinard maneuver, delivery of the extended legs. Okay, pinard's maneuver, extended legs. Lauset's maneuver, delivery of the extended arms. Merrick Smiley-Viet maneuver, delivery of the after coming head. Okay, yes. So what is the option A then? Arms delivery, that is Lauset's maneuver. What about option B? McRoberts maneuver, Rubin's maneuver. Yes, McRoberts, because shoulder dystocia, McRoberts maneuver. Then followed by Rubin's maneuver if it is failed. Okay, then wood screw maneuver will be doing. So C option is Merrick. Okay, Smiley wet maneuver. What about option D? This maneuver. Okay, is clear? It's clear. Okay. So the 20 questions we are finished. Okay, all the very best and thank you. Okay, so what is the exam tip which I'm going to say is read whatever nozzle pattern questions previously asked in OBG. If you're covering today OBG, take your book and whatever MCQs they have asked in previous year, learn the concept, revise your concepts, and go for the exam. Okay. Soon, Monday, I'm going to back to the session. We'll be mentioning the timings as well as okay, and we'll be discussing community health nursing questions there. Possible questions and updated questions will be learning there. Okay. Signing off. Very all the best for your exam by your faculty Muthukumaran. Next class will be seeing community health nursing. Thank you all.